So good afternoon, everybody. My name is Heather Hadjistavropoulos, and I'm a professor of psychology here at the University of Regina, and one of the faculty members that's involved in the Western Regional Training Centre. Dr. Greg Marchildon, who's the director of the Regina site, is unfortunately not able to be here today, so I have the pleasure of introducing everybody. Just one thing to tell you about is, you can't see this, but we do have a Saskatoon audience that's also joining us. And I think there's another audience from another site as well. They wanted me to announce that there is a conference that's coming up in Saskatoon, and it's called the Bending the Cost Curve in Healthcare. And it will be held on September 27th to 28th, and I think everybody was given a handout on that, so it looks like it has an interesting lineup. Oh, that's very interesting. I hadn't looked at all the speakers as well. So this afternoon, Dr. Thomas Hadjistavropoulos, somebody I know a little bit, will be coming to introduce Dr. Koocher, and we should actually be very grateful to him because it's through his connections that he was able to bring Dr. Koocher to speak at our seminar. And Dr. Thomas Hadjistavropoulos is a professor of psychology and chair in the Center of Aging and Health. Chair of Aging and Health. I should know this. And he's also one of our experts within our department on ethics. And he's going to say a few words to begin with on the Canadian healthcare system and psychology within that healthcare system. So on that note, please welcome Thomas.
Okay, before, I'm assuming I have to stand here because of Saskatoon, right? Yes. Hi, Saskatoon. So before I introduce Dr. Koocher, I'll just say a few things about how psychologists in particular are funded in Canada, how psychological services are funded in Canada, so that we have a context and a comparison standard for what Dr. Koocher will discuss. I'll take about 5 to 10 minutes at the most to do that, and then I'll introduce Dr. Koocher. So rather than me doing all the work, I thought that I would select from among the most vulnerable members of the audience and ask them to tell us how they think psychological services are funded. I decided the most vulnerable members of the audience would be the first-year graduate students in psychology. So, Amy, how do you think the psychological services are funded in Canada? And again, everybody keep in mind, she's a first year, she just started the program. Let's see.
I think it would depend maybe like the circumstance, because I know at like some hospitals they might be covered through like the hospital care, like at cancer centers.
Okay, that's true. And Kirsty will help you, another first-year student.
That sounds really good. But the government provides funding too, right, for public health centers?
For mental health clinics that employ psychologists. But the bottom line is that in Canada, as Jerry has heard, we have a Medicare system that covers most essential services, healthcare services, as the public policy people know well. But psychological services are not covered by Medicare. So if you go to see a psychologist, that psychologist cannot bill Medicare for the service, they'll have to bill you. Usually it's direct billing. So private psychologists, it's only direct billing. A small number of people, including faculty members of the university or other members of bargaining units at the university, have private insurance for psychologists. At the U of R, that insurance is $300 a year, which would cover about a session and a half. If that, if you're in Ontario, it wouldn't even cover that. So there is a little bit of private insurance, not much. So what do people who cannot afford a psychologist do? Well, they may see people who are less qualified, who have less training, they may see counselors. Or they may go to publicly funded mental health clinics, like it was mentioned. Sometimes psychologists are employed in hospitals. These psychologists are salaried. So if you go to a mental health clinic, you typically have to wait on a waiting list. It could be several weeks or it could be months. And then, if you're lucky, you'll see a psychologist locally in Regina and the Regina Mental Health Clinic. If you are referred to for a problem, you may see a psychologist, you may see a social worker, or you may see a psychiatric nurse. And you have no say as to who you want to see. But if you see a psychologist, they probably will not see you very often because they have a very high case volume. They might see you once every couple of weeks. And the final method of reimbursing psychological services is through employee assistance programs. Some companies have employee assistance programs, like the Royal Bank of Canada. They have contracts with psychological firms, and then their employees can go and see a psychologist for a limited number of sessions. I would say usually around 10 per problem. And then they do some juggling. Well, I treated you 10 for depression, but you also have anxiety, so we get another 10 sessions. However, these EAP employee assistance programs most often do not include psychologists. The Royal Bank is one that I know does, but most EAP programs do not include psychologists. They often include unregulated providers such as counselors. So psychology is mostly for the privileged and the wealthy in Canada, and opportunities for the less fortunate financially are more limited, or they have to wait. So that's it in a nutshell. Any quick questions about how psychological services are funded in Canada? Okay. Now, the most pleasant part of my being up here is to introduce our speaker, Dr. Gerald Koocher. Now, he is probably the best-known ethics scholar in psychology, or ethics and behavior scholar anywhere in the world. He has published 14 books, and his book, Ethics in the Mental Health Professions for Patricia Kiss-Spiegel, I constantly recommend it to graduate students taking comps. It's a must-read. It's a Bible for any mental health practitioner. I tell students, if you know everything in that book, if you practice the dilemmas, plus the CPA code, which is not covered in the book, maybe in the next edition, you'd pass comps. So that's a very important contribution. But he's also published 200 articles, including one in Nature. Nature and Science are probably the two most prestigious journals across all disciplines. To publish an article in Nature, you typically have to be a basic scientist. To publish one in ethics, it's practically impossible, but he's done it, and he's published an article in Nature on scholarly misconduct. Now, he also has a lot of knowledge of the US healthcare system, having served as president of the American Psychological Association, president of the Massachusetts and New England psychological associations. He's been in charge of units at Harvard-affiliated hospital. I think, is it the Mass General? Yeah. Oh, the Children's Hospital in Boston. So published 200 articles. His trade, in quotes, is he's a pediatric psychologist and still practices for half a day a week. Presently is associate provost at Simmons College, which is a small college in the US, but yesterday in Boston, but has some very prestigious programs, as I've been learning, and has more graduate students than it does undergraduates. So I think that's a very good model to follow at the U of R to get more graduate students. So not only has he been influential through his scholarly work to what we do as mental health providers, those of us who are psychologists, but I also learned yesterday that his daughter has also been influencing what we do or watch. His daughter is a producer, a TV producer in New York, and has produced shows such as The Bachelor and The Real Housewives of New York City, which represent secret vices of many academic scholars. Of course, I wouldn't know firsthand. But there are two yardsticks I use to evaluate scholars, and one is output, which is what they discovered. The other one is mentorship. And he's an outstanding mentor. He's been an outstanding mentor to me. About 18 years ago, I wrote to him asking him, "Oh, will you let me guest edit an issue of your journal?" And not only did he say yes, but mentored me through the process, has been mentoring me, giving me advice in many ways, helped me a lot in my career. I appreciate it. I'm delighted you're here, and welcome to the presentation.
I'm delighted to have a chance to meet and talk with you, and I'm going to talk today about some things that are sort of unusual for psychologists, which include the economic underpinnings of psychological practice in the United States. So you can think about those in terms of public policy implications as you perhaps launch into a career in human services in Canada as well. And I begin with that title, "Do they pay you to do that?" Which is a paraphrase from my dad, who was a plumber with a 6th grade education from a generation when you didn't talk to people outside the family about emotional issues. And long after I'd been working at Children's Hospital Boston, doing direct service in pediatric psychology, he said to me one time, "So, people pay you to talk to them?" And I smiled and said, "Yes. Tell me some of what you say that's worth money." So in that case, I thought I would get into these issues and take you on a brief sojourn through the microeconomics of insurance. In the 1980s, when I was full-time on the Harvard faculty, we got to take one course free anywhere in the university every semester. So I essentially did the equivalent of a master's in public administration at the Kennedy School, looking in particular at microeconomics of insurance, because we were heavily involved in lobbying both in the legislature and with healthcare insurers about how to get reimbursed for services. The cartoon you can't read on the screen talks about someone, a 52-year-old male, admitted last night with mild chest pain and a really first-rate kick-butt Cadillac with an insurance policy. And if you can see the cartoon, he's connected to all kinds of apparatus and has many people taking care of him. So we immediately see some of the externalities that economists will talk about. And just as an aside, I have left copies of this presentation, so any of you who want a copy of the PowerPoint because you can't see it or whatever will be able to get it. Think for yourself now how you feel about some things we're going to mention, because I want to get into talking about the moral hazards, so-called, of insurance. But first, I want to let you know that I own an insurance company, Koocher's Insurance, and we have a special deal open today. Do any of you own aircraft or ocean-going cargo vessels? It's too bad, because I have a sale. For $100, I would give you full first dollar coverage with no deductible for a year. Anybody want to buy it? But you must be rational people then, at least up to a degree, because rational people will not seek insurance unless they think they might have a need for it. And I was offering you a product that I knew you had no need for. There are some people who will buy things under those circumstances, but not many. But how do you feel about your health? And the caption here is, how long do you want to live? Then there's, how do you feel about your mental state? And if you're a graduate student, we know how you feel. Then you could think, how do you feel about your nose, your breasts, your body fat distribution? Because all of those become relevant in the cartoon as the woman telling her physician she'd like to have her brain transplanted into the body of a mindless, attractive young person. So what I want to talk about, beginning with, is focusing on moral hazards of insurance. And I'm going to focus on mental health and plastic surgery, because they do have some things in common. That is, there are some people for whom mental health becomes critical, as does plastic surgery if you're born with a cleft palate or if you're a burn survivor, because you urgently need help to be able to accommodate, fit in, get pain relief, have your symptoms go away, be able to survive in society. But there are also people who've been referred to by some American insurance companies as the worried well. do they really need psychotherapy? Should we be subsidizing their care? And there are people who need or are interested in all manner of plastic surgery, from liposuction on up or down the list. Take your choice. I don't think I need to elaborate on that. The first moral hazard is the ex ante, or the before moral hazard, and that's what I was just giving you the example of. People do not buy insurance unless they anticipate needing it. Then there's the ex post moral hazard. If you have insurance, you are going to demand, in the concept of supply and demand, the best coverage and the fullest coverage. The example I typically use is deductibles on automobile collision insurance. If you own an automobile and you have collision insurance with a $500 deductible, and you get a scrape in the parking lot that is going to cost $100 to repair, if indeed there are repairs that only cost $100 these days, you may decide to drive around with the scratch for a while. Your insurance isn't going to touch it because you have that $500 deductible. If, on the other hand, you have $1,000 worth of damage, you may well choose to get it repaired because the insurance company is going to pay half the cost, but you're going to insist that they use original factory replacement parts and that the paint job lines up perfectly and so forth. So those are part of the moral hazard issues. There is adverse selection that comes in with both mental health and plastic surgery. I'm sorry, my eyes aren't good enough. I'm going to have to wander over here to prompt myself. And this is a quote from Frank and McGuire, which I'll give you the reference to. Demand response to insurance coverage for mental health services is greater than that of other medical services, and therefore the welfare loss from coverage is larger, while the risk-spending benefits are similar. That's the health economist speaking. In the United States, the best example of this occurred with federal employees. If you happen to work for the United States government, whether it's for the FBI or the Veterans Administration, the State Department, you, as a federal employee, you used to be able to have an insurance plan, and you could choose the high option or the low option. This is in the days of indemnity insurance, where you would just get someone to pay for the problem that you had, before the era of health maintenance organizations and preferred provider organizations. Just straight up insurance. The high option, if you chose that option, which was a little bit more in payroll deduction than the low option, gave full coverage for mental health benefits. A lot of people went to work for the federal government, most notoriously the Veterans Administration, because they wanted to train as psychoanalysts. Think 5 times a week psychotherapy. Intended primarily, maybe they were neurotic or maybe they were obsessive, but primarily because they wanted to become analysts, and this was a part of their training. And think 5 to 7 years of training, 5 times a week, and the government was paying for all of this. This is one of the things that gets in the way of demanding the best services you can get when it costs you nothing. When the cost to you is minimal, the ex-ante moral hazards. And I've given you the reference there for all of this material. But that's one of the key problems that underlies some of the insurance industry's concern about psychological benefits. For those of you who don't understand the economic term externalities, I have a cartoon for you. It shows a grave digger and the fat man representing big tobacco is telling them that the increases in the cigarette tax are going to ruin your job. People will not smoke as much and you will have fewer graves to dig. But there are a lot of things that economists get into in talking about externalities. And I've given you their definition of the externality, but there are 3 externalities with respect to mental health that I wanted to call out for you. It's been estimated by the American Psychiatric Association that about 4% of the American population suffer from significant chronic mental diseases, such as schizophrenia, major depression, bipolar disorder. Canadians are more polite, but then again, you're darker for longer periods of the year, so I don't know how seasonal affective disorder, how things kick in to change the picture in Canada. existing treatments for mental illness often do not cure the condition. If you have OCD or conversion disorder or low self-esteem or some other mild issues, psychotherapy can make a big difference and help you accommodate and get over it. But if you're dealing with bipolar disorder or schizophrenia, we're really talking about long-term management of the issue. Finally, pharmaceutical companies, managed care entities, and assorted provider groups have competing interests that don't necessarily align with those of the patient. The pharmaceutical companies want to make money on their newest, latest, and greatest drugs, and they don't necessarily want to look at, does psychotherapy do better than the drug? One of the classic illustrations of how this gets played out in the insurance industry in America is we know from a lot of psychological studies and meta-analyses that depressed people will do better in coping with their depression and getting relief from their depression with a combination of medication, antidepressant medication, and interactive psychotherapy. The insurance companies would much rather say, well, let's try the medication first and see if that works, because then we're not adding in an incremental cost. So if someone's promised to buy you an automobile, are they going to buy you a 20-year-old Volkswagen, or are they going to buy you a brand new Lexus? They're both automobiles. And of course, the insurance company wants to get your best outcome-based advice at the lowest cost. They want an efficient program. What is it that you need that's medically necessary and will provide reasonable coverage for this condition? And it's not always easy to sort that out. I've provided for you 2 reports, and this is a graph from one report just showing where insurance comes in the United States. And the largest red section of the pie chart is for any private insurance. The pink section, which says Champus and VA only, Champus are civilian employees of the U.S. military. So the red and the pink are really the true insurance coverage percentages in the United States. And you can see in the report where the other types of insurance for substance abuse and mental health coverage come from. But there's more adverse selection in mental health and substance abuse treatment. And one of the reasons for the adverse selection is that, as I alluded to earlier, we are not going to cure the condition. We are hoping to manage it and help the person become employable or reintegrate in society, function effectively in their neighborhood. One of the problems is that mental illness is often comorbid with other factors, which may or may not be dealt with, such as housing, income, mental illness and substance abuse, poverty. All of these can interact. If you can't work, you're in a poverty situation. If you're poor, you may not have insurance. If you don't have insurance or can't buy your medication, your treatment becomes inadequate. And we're into a vicious cycle that is a challenge to break out of. And oftentimes, these people will end up in the criminal justice system. Massachusetts now has a universal health care plan. Alternatingly, Mitt Romney either takes credit for it or says that he had nothing to do with it. Actually, it was the Democratic legislature in the state that pushed it. Romney was the governor, and he helped tweak it and sign it. But it works something like this. If you are a Massachusetts resident and you do not have health insurance, then when you file your state income tax return, assuming you have made enough income to file a tax return, you have to pay a fine. The fine rate ranges from 0 if you're very low income to as high as $600. Not a big issue for a lot of people, but it forces people into the pool. One of the problems is it's hard for some people to get insurance. We'll get into that in a minute. Another issue is that some people who perceive themselves as at low risk do not buy insurance. The classic group are healthy young men who feel invincible and are not at risk of getting pregnant And so they're, by the way, you cannot go out and buy pregnancy insurance. Why? Post-menopausal women and guys would not buy it. So pregnancy expenses are bundled into a family premium for policy for that very reason, adverse selection. So what we have now in Massachusetts is a situation where several years into the program, 6 years into it now, and I'll just read these statistics to you, 439,000 people who did not have insurance 6 years ago are now insured. 83% of those people are insured through a publicly funded program. We went from having 90% of our residents insured to 98%, the highest rate in the United States. And although 2% of our residents are not covered by insurance, that compares with about 16% in other states. Now, what that took was the state of Massachusetts deciding to make a budgetary investment in making low-cost insurance available to people who are otherwise uninsured. But it was an enlightened self-interest decision because prior to this, people who had no insurance would occasionally show up in the emergency room and be treated because they've shown up in the emergency room. But wait, they don't have insurance, so the state is ending up having to reimburse hospitals in some way for delivering that emergency service that could have been prevented if the people had a primary care physician or were getting routine care in other ways. And in fact, what we have seen in Massachusetts over the past couple of years is that emergency room utilization has gone down as this coverage has increased. So our state is very happy with the plan. We are trying to tweak it a little bit more and moving toward something called a global payment system, which is a form of care rationing that in theory is going to make the healthcare system better, but I'll get into that in a moment. But I thought I would use that as an example. In states and our two territories, Puerto Rico and the Virgin Islands and the District of Columbia, all differ in their jurisdictional coverage, what services they'll provide, especially if the services that they'll provide are the same if you buy insurance. But they differ markedly if you rely on the state Medicare or Medicaid or state-funded plans. So those are the difficulties. Now, under the fee-for-service method, which really got its start at the end of the Eisenhower administration, the idea was we were starting a Medicare program in the United States, and there were one of the unique things about America, which I imagine a lot of Canadians chuckle at and should, is some of the misguided views that people have about their freedom. Like I was discussing with Thomas at dinner last night, in my state, if you want to own a firearm, you have to get a variety of permits, and there are waiting periods, and you have to take classes, and you can't have a criminal history or a mental hospitalization history. In the state of Virginia, you can buy at least 7 guns a week. And as we saw in the Virginia Tech shooting, there's no waiting period or screen out for people who are former mental patients. And of course, we also have states like Texas and Florida, when just about any citizen has a right to carry a concealed weapon. And that's because of freedom. So we have some people who are sort of hooked on freedom in ways that seem somewhat perverse. But in the Eisenhower administration days, we didn't want socialized medicine. That was akin to communism. And the American Medical Association didn't want to be forced to have government regulators tell them how to practice medicine. So the government is thinking, how do we get people into the system? How do we get providers to sign up to be taking care of these people that we want to insure? There were other things happening in medical care at that time, which were saying the government has to help. The classic example was the End-Stage Renal Disease Act. We had invented dialysis, and we were in the early stages of kidney transplantation. But there were far more people needing dialysis than we could accommodate at the time, and there were actually ethics committees set up to decide who would get dialysis and who was going to have to die while waiting for a transplant. But because of the End-Stage Renal Disease Act, which is part of Medicare, anyone requiring dialysis gets it for nothing. So we wanted people to sign up as providers. So the government created a fee-for-service model, sort of like a la carte, where you pay each server in the restaurant for what they deliver to you. So obviously it's in the server's interest to deliver as much as possible and as many different units as possible. So for example, psychiatry in the hierarchy of a major medical school is at the bottom of the totem pole. Why? At least in the old days, psychiatrists, you would spend an hour with a patient. Nowadays, by the way, very few psychiatrists are doing psychotherapy because they can pack in 12 psychopharmacology visits and make way more money. Number of procedures, you're getting paid by the procedure. And everybody has a different procedure. So you need to go to the radiologist for that CAT scan. And by the way, there are some radiology groups in the United States that buy their own CAT scanner and will run it 24 hours. And if you want a cheaper CAT scan, you come in at 2 in the morning rather than between 9 and 5. And oh, what a coincidence. Those radiologists whose patients need a CAT scan tend to get referred to their own CAT scan company. And so we had physicians who were doing all manner of creative things, all legitimate, to generate flow. In a major hospital, the most lucrative departments are those that are procedure rich. People who read x-rays, radiologists, lots of procedures, lots of x-rays to be read, cardiologists, lots of cardiac procedures to be done. And then, of course, surgery is rated differently, but I was telling Thomas yesterday that the highest paid faculty member at Harvard University is not the president, it's a professor of surgery. And even the dean of the medical school, and actually I think the dean of the business school, both make more than the president of the university. But that's, again, social value assignment. So under the fee-for-service model, the historical context was to get people in, and the procedure-based payment system has no focus on quality, it's just how many units of service can you deliver, and that yields poor quality and high prices. And so the trick is, how do we move on from there? Now there are, U.S. healthcare system is highly responsive to supply and demand, but it's a shabby patchwork of coverage. There's no comprehensive national mandate. It's too expensive. There are no real constraints on cost growth. Many people are uninsured. There's inadequate attention paid to quality of care or integrated care. I'll talk more about that. And there's an inadequate focus on preventative care, avoidable conditions, chronic illnesses. And this is going to be an increasingly important role for people in health psychology because of things that I'll mention in a minute. There's a Harvard Business School professor named Michael Porter who writes on virtuous circles of care. And one of the things that Mr. Porter likes to write about, for example, he cites a headache clinic in Heidelberg, Germany, again, funded by the German government because everyone has the same health care plan, where if you show up with a migraine headache, you're at a clinic where there is a spine surgeon, a neurologist, a physical therapist, a dentist, because TMJ can contribute to migraines, a psychologist who works on stress reduction, pain specialists. Everybody's at the center. And your migraine gets managed by a team. And they're responsible for your migraine. And so the thing that people like Porter and others are arguing for is we ought to have a health insurance system where you get rewarded for managing the condition and for really keeping people healthy, as opposed to fee-for-service, fee-for-service, fee-for-service. Because you can just keep getting people back but not paying attention to the quality outcome. Now the downside of this is you need more control over the patient in order to do that, and that interferes with your freedom. So if you go to your primary care physician and they're part of a group that is getting a so-called global payment for delivering services to you, they want to keep you healthy. They think you need to see a specialist for some reason. So they'll say, I'd like to send you to Dr. Jones down the hall. Dr. Jones is part of that group. And you say, no, I want to go see Dr. Schmidlap over at Mass General. Dr. Schmidlap is outside of the group. That's a fee-for-service payment. Now, in the current model, you can often go to see Dr. Schmidlap, and it may cost you an extra premium. It may cost you a higher co-payment to see an out-of-network provider, but that's your choice. If you have the disposable income and want to do that, you can go to see Dr. Schmidlap. But wait, Schmidlap's medical record system may not be the same as in your network. Dr. Schmidlap may not take the time to write a letter back to your primary care. The plan that Dr. Schmidlap recommends for your treatment may run afoul of other conditions or medications you're taking that Schmidlap doesn't know about. Of course, one of the things that's happening in the background now is that the federal government in the United States is trying to incentivize physicians all over the country to buy into a uniform system of interoperable medical records. This gets to a number of other issues, but just aside, interoperable medical records, I don't mean simply an electronic version of a paper document. I mean the ability of Dr. Schmidlap to open his file and look at what your primary care physician is doing and has already tried with you. But wait, that interferes with your freedom. There was a case that came up recently where a woman went, there's a very large healthcare network in Massachusetts called Partners Healthcare, which involves Mass General Hospital, the Brigham and Women's Hospital, and a few others. Probably covers about 7,000 hospital beds, 7,000 to 10,000 hospital beds, and probably cares for about half the population that's insured in the state. And she went to see her internist, and her internist said, oh, I see you're getting psychotherapy from so-and-so. She didn't want her internist to know she was getting psychotherapy, but he could see that in the partner's record. So there are quirks about how the system will work, and what do you want to share and what do you not want to share, and can you compartmentalize your privacy? That's one of the ongoing struggles. Some of the key concepts that you want to think about are, and I've listed them here, and I'll go through them just so you can understand them from the American perspective. The first one is called co-insurance. That's the way insurance companies want to deal with the moral hazards. You want to have an investment in your own health care. Now, of course, we all want to be healthy, but they're referring to a monetary investment. So that's a deductible, or it's a co-payment. The insurance plan that I have through my university, my wife and I each have a $500 a year deductible, meaning that the first $500 a year of any medical expenses that we incur, lab tests or whatever, we have to pay out of pocket. After that, any hospitalizations, lab tests, etc., are paid for. If we go to an outpatient office visit, we have to pay $20 co-payment at the time of the visit. But that's all that we have to pay, that $500 and the $20 co-payments, and the co-payments count against the $500. That's just one example of one plan, but the company is saying to itself, the insurance company is saying, we are sharing the risk with the person. So if you're going to sign up for psychotherapy, your co-payment might be a percentage of the fee of the person who's providing the services, or it might be an hourly rate. But that shows that you are sharing the risk with the insurance company. Then we have the traditional indemnity plan. It means you have insurance, you show up, you pay the insurance premium, and they pay your bill. That's increasingly rare. It's especially increasingly rare with first dollar coverage. There are still some indemnity plans running in the United States, but they often have high deductibles. Then we have something called a point of service plan. That's where your primary care physician is the primary gatekeeper. It's the plan I sort of alluded to before, when he wants to send you to a specialist down the hall, but you want to go across town. And these point of service plans generally have a certain premium rate, and if you choose to go out of network, you pay a higher percentage of the cost of that medical care outside of the system. Then we have something called preferred provider organizations. Those are networks where it may not be a limited venue where you would get seen. You could go to anyone in the network. This is one of the things that typically happens in mental health care, since a lot of hospitals and clinics for medical care don't necessarily have mental health practitioners right on the premises. So they will say, oh, you need psychotherapy, and your primary care physician says, well, I'll approve psychotherapy for you. Here's the list of people who are in our network. Now, this is a contracting arrangement. If you're licensed and eligible to be a mental health provider, you can submit your credentials to the insurance company and sign a contract with them to become a preferred provider. And what that means is that you agree to accept in full payment for your services whatever the rate is that they've set. So if you would normally charge $100 an hour for a psychotherapy hour to a client that was paying the full rate, but the preferred provider rate for the Blue Cross Blue Shield of Massachusetts is $66, you agree to accept the $66 plus the copayment, whatever it is, and you have sworn in that contract that you will not bill the client for the difference. So from the insurance company's perspective is they're negotiating a better rate for potential quantity referrals. From the provider's point of view, if it's a big insurance company, I damn well better sign up with them and get on their provider list, or a lot of people aren't going to be able to see me and get some coverage. But there are, of course, sacrifices, because insurance companies are very loath to increase what they're paying. In fact, about a year or two ago, they reduced what they were paying for some mental health services. And also, it might be hard for you to get into the network. If you're applying to a preferred provider network that is already crowded, that might present an interesting challenge. One of my former students, who's the hearing child of deaf parents, finished her internship and went out to live in Los Angeles. And I also knew, although it's obviously irrelevant to her skills as a psychologist, that she's a lesbian. And so Louise calls me a couple of weeks later and says, I'm having a difficult time. I'm working full-time. I want to do a part-time private practice, but I can't get on any of the preferred provider groups. I said, Louise, you're living in West Hollywood. Have you told any of the groups that you have experience in working with the gay and lesbian community? She said, no. I said, have you told any of the preferred provider groups that you're fluent in American Sign Language? And she said, no. I said, try that. She was immediately admitted. Why? Because there are people who say, I want to go to a gay-friendly therapist, not someone who's going to suggest religious conversion as a treatment for my being gay. And the Americans with Disabilities Act requires that insurers provide people who could do American Sign Language for deaf clients. So again, it's how you position yourself to get into the network if you want to be in the network. Health maintenance organizations were originally set up. Kaiser Permanente was the first one in the United States. The idea was, we're going to keep you well. We're going to maintain your health. Yes, the primary care physician is going to be the gatekeeper for all specialty services. And we're going to have a physical facility as opposed to a network of people. And we'll have some psychologists and social workers and psychiatrists on our staff who will serve you in our building. Again, some people like that model, some people don't. One of the difficulties gets to be in the next category, which has to do with carve-outs. If you're providing insurance for mental health services or substance abuse services, do you want to be providing it that yourself, or do you want to subcontract it to another set of providers? So say you're a health maintenance organization and you have a lot of physicians and nurses on the payroll. You want to hire a bunch of psychologists or psychologists and psychiatrists, not knowing what the demand for their services will be, not being predictable in the same way that you can tell that having a certain number of physicians can cover in general, the health needs of a certain population. So one of the things you might do is subcontract with a bunch of people to provide those services. One of the problems in the early days was that there were capitation models. So let's see, I'm getting $1 of health insurance for someone, and I'm a big health insurance company, and I decide 4% of the people are going to have major mental disorders. Well, let me say, I'll allocate 5 cents of that premium to mental health coverage. Now I will go out to the University of Regina Psychology Clinic, and I'll say, would you like to cover all of our patients' mental health needs? We will pay you 5 cents per dollar on the patient. And we have 200,000 patients, and they are all paying us $1,000 a year at premium. So that's $500 for each of those patients, and you can get that money, and we'll give it to you cash on January 1st. And all you have to do is provide their mental health care for the rest of the year. Well, it might sound like a good deal, but what if you have a couple of people who need to be hospitalized in a psychiatric hospital, and you need to pay that out of your premium? Or what if there's a major disaster and you have a lot of depressed people coming in who want reactive depression treatment? Imagine the scenario. The incentive that you have is to provide as little care as possible, because you're getting the money regardless of outcome. So it makes it very hard for someone to get into the hospital. Some of our psychology interns work in the emergency room, Children's Hospital Boston, and one of the first things they have to learn if they have a kid in the emergency room who's a suicidal attempter or who's in need of psychiatric hospitalization is what kind of insurance do they have, because where you can get them a bed if they need to be admitted will depend a lot on their insurance coverage. So again, the patchwork makes things very messy, and the system is not at all uniform. So we now have mental health parity in the United States, at least in theory. The cartoon says here, the person talking to the health maintenance organization, you don't have mental health, you don't cover mental health completely as you cover other illnesses, and the HMO guy says, correct. She says, isn't that discriminatory? And he says, so you have a problem with paranoia. So we do have, in theory, a Federal Parity Act, where the federal government says that you must provide the same level of treatment for mental illness as you do for physical illness. So if you have a patient with cancer and you're providing full coverage for their cancer treatment, then if someone comes in with schizophrenia, you can't tell them, sorry, your mental health coverage is limited to $1,000 a year. Previously in Massachusetts, we had, before that mandate came in, we had $500 per person per year mental health coverage that was required in every insurance policy written in the state. Maybe that would cover 5 visits. And then we would see things happening in the child therapy market. We would see things happening like musical chairs. Mrs. Jones would bring Billy in, and Billy could get 5 sessions. So then we'd start billing Mrs. Jones for collateral treatment to treat Billy, because she had 5 sessions. And then we'd start billing Mr. Jones. A family of 4, you might be able to squeeze $2,000 out of it. Well, now in pushback to the Federal Parity Act, a lot of insurance companies are trying to squeeze in the definitions and say, well, that really only refers to mental illness that has a biological basis. So schizophrenia, autism, bipolar disorder, we'll treat those for as long as you need treatment, and we'll treat them with medication. But psychotherapeutic services of a non-medication sense get to be more of a problem in that way. Under the new system that appears to be emerging under the so-called Affordable Care Act, which some people are calling Obamacare, there will be incentives to set up accountable care organizations and global payment systems, as well as insurance cooperatives, so that other states can get the kind of thing we're doing in Massachusetts. Massachusetts state legislature just passed a law anticipating that the federal government might, the Republicans in Congress might try to undo that, trying to set up a global payment system in Massachusetts. It remains to be seen how that's going to get played out from a rationing perspective. Because again, when is the care that you're seeking for yourself medically necessary? How do we define medical necessity as it applies to psychic pain and psychic disabilities? Here we have a person lying in bed and the physician is saying, her HMO coverage plan ran out, they recommend a physician-assisted suicide. Again, a very controversial area in the United States. In Massachusetts, on the November ballot, there will be a physician-assisted suicide bill. If people who are terminally ill are interested in that in the United States now, they have to go to Seattle. We also have payment models from the practitioner perspective, get 50% off or half price, whichever is less. Insurance-free care providers, indemnity coverage. These are the payment models from the practitioner's perspective. The insurance-free ones, my daughter, who's a television producer who lives in Manhattan, she has had type 1 diabetes since she was 8, so she has an endocrinologist, a diabetes doctor, a gynecologist, and an ophthalmologist, none of whom take her insurance. They only take fee-for-service practice. And in Manhattan, you can get away with that. There are people who have the disposable income who will pay for service. Now, she has health insurance, and she has a primary care physician, but she has chosen to use some providers that are outside the system. They say, we don't buy into the insurance. A couple of years ago, when I leaped from being a full-time clinician at Children's Hospital Boston to being an academic dean and provost, I tell people I fled managed care into academia. I was mostly treating kids with chronic and life-threatening illness, cystic fibrosis, cancer, and so forth. I would have to phone in to the managed care company every 3 or 4 sessions to get authorization for another 3 or 4 sessions. So now, when I do my private practice, I do it for the hospital, and I let the billing department at the hospital worry about it. And if I take on private patients myself, I don't bill insurance companies. Just can't afford the time and effort and aggravation to do it. Indemnity coverage, where it still exists, or signing up for a preferred provider organization, there's a problem in the States with what's called any willing provider options. The PPO, or the health maintenance organization, doesn't have to accept you as a provider. I use the example of my former student Louise from West Hollywood. Louise was a highly desirable provider because of the skill set that she had. Suppose you're a very highly skilled but nothing special clinical psychologist and you want to enter a market that's already crowded. How are you going to get on the provider panels? There have been some efforts to say that the provider panel should take any willing provider, anybody that's willing to sign the contract that says, I accept your rate. But there are some states where there are insurance companies that still won't do that, and state law doesn't force them to do that. Health maintenance organizations, some have open panels, meaning anyone can sign up and be on their panel. Some have closed panels that are site-based, meaning you have to go to their site and see their employee. Now, this can be both good and bad. The most positive example in the United States is probably the Mayo Clinic. All the physicians and psychologists at the Mayo Clinic are on salary. The hospital does bill for procedures, but you're paid a salary and you're expected to keep up your end of the load, but you don't increase your salary by seeing more patients and doing more procedures, which does focus things on patient welfare. And I referred to Professor Michael Porter from Harvard Business School, but the whole idea of value-based integrated care is something that we're talking about and hoping to achieve. What I've given you here on this particular list are a list of diagnostic controversies that appear on the Diagnostic Statistical Manual of the American Psychiatric Association. You can be coded as having non-compliance with treatment, partner relational problems, sibling relational problems, occupational problems, academic problems, acculturation problems, bereavement. They're listed as so-called V codes, meaning they're a focus of treatment. So you've just lost both of your parents in an automobile accident and you're terribly depressed and you want to go to see a mental health professional. Did they have to diagnose you as having major depression? Well, of course not. You don't even meet the criteria because it hasn't lasted at least 6 months duration. Do they have to give you a pathology diagnosis like adjustment disorder? I suppose they could, but they could say that they were treating you to help you with bereavement. Now, in the Commonwealth of Massachusetts, our state insurance commissioner has ruled that if it's in the DSM, the insurance companies have to cover it. There are states that say if you've got one of these conditions, it's not covered by your health insurance. So how do we treat things? Do we treat things with evidence-based practice? Do we have practice guidelines? I'm giving you an example, and I'm not going to go through it because I want to leave time for questions. But what I've done is I've taken the case on this decision tree of a youngster who's presenting with behavior problems. And your differential diagnosis is between oppositional defiant disorder and attention disorder with hyperactivity. And I've given you here a decision tree that shows you how you could make a decision on an evidentiary basis. And what you first do is think about all of the alternative diagnoses on that chart and ruling them out. And then you make a decision. And the decision would be, are you going to try to treat it with a prescription? Are you going to try to do a prescription? Which drug are you going to use? Are you going to try family therapy, group therapy, individual therapy? How are you going to target your intervention to fit both what the evidence tells us about what's effective with ADHD or ODD, if that's the diagnosis, and what the family's preferences are and what their cultural needs and so forth are? You can put your program together. What really happens in the United States, 70% of all the prescriptions for psychiatric medications are written by general practitioners, internists, or pediatricians. So what's more likely to happen is the kid is going to get taken to their local pediatrician who is going to prescribe Ritalin or Adderall. Or if this is a person who studied with Joe Biederman at Mass General, he'll immediately put the kid on mood stabilizers and diagnose him as pediatric bipolar. You could get me off on a riff on that about the whole invention of the diagnosis of pediatric bipolar disease by pharmaceutical companies. And if you want to Google Joseph Biederman, Mass General Hospital, you can find out how Harvard disciplined him for forgetting to report $1.6 million here and giving lectures to drug companies. The other thing that I have here are new current procedure codes that apply to, these are the old ones that apply to mental health care, things like individual therapy or family therapy. But then we're going to have some health psychology related ones. Psychology is a healthcare profession, but wait, the conditions that tend to kill people in the developed world include things like non-adherence to medical regimens, smoking, obesity, substance abuse, and accidents and domestic violence. And here you see Weight Watchers upstairs from Baskin-Robbins. And here you see from the 1950s a physician recommending Lucky Strike cigarettes. And here you see a father teaching his 3-year-old to shoot. There are lots of things that we could get involved in. And just as an aside, I think it's a funny picture, but there was some litigation in Florida early this year because the American Academy of Pediatrics wanted to recommend that parents of young children should not have firearms in the house. And the National Rifle Association tried to influence state legislation in Florida to ban any Florida physician from counseling parents not to have weapons in the house. These are health and behavior codes, which in the United States you can now bill for as a mental health professional. For example, reassessment of treatment of a patient to determine the biological, psychological, and social factors affecting the patient's physical health condition. And there are a lot of us who do that. There's also fraud as a major cost. I've given you some examples. One recent incident in the United States was they discovered that there was a group in Florida that were billing for verbal psychotherapy with Alzheimer's patients, not an evidence-based practice. And to make matters worse, some of the people they were allegedly treating weren't even living in Florida. So outright fraud, that is a big problem. And you see this coming up in the political campaign. Obama has said he wants to save $760 million by focusing on reducing fraud. And Romney turns around and says, see, he's trying to cut $760 million out of Medicaid. So, and I want to give you time for questions, but I thought I would close. This is the HMO appreciation paper. There was a song.
We all need insurance, especially for our health. There's Junior, Joan, Grandma, and don't forget yourself. Call Comprehensive Family Insurance, that's our name. We vow to try at CFI to win the healthcare game. Come on and sign with CFI, you'll never feel the same. CFI Care, that's our HMO. Just tell us where you're hurting, we'll tell you where to go. The compassionate, efficient, and humane third-party payer. If you get sick, just call us quick. CFI Care. Suppose you want a CAT scan. Well, hold on, not so fast. Your headache may be killing you, but who says it'll last? Just keep on popping aspirin and wear that bag of ice. That's our favorite cost-effective, outcome-based advice. That's
I'll leave the song on the computer, so you have this. They do have some advice for people. One of the characters is out on the ledge, and they suggest the Heimlich. It's the standard protocol. But this is the key problem. How do we put quality into the system, and how do we cover people at affordable cost? Now I'll shut up and see what questions come.
So we'll maybe start with some questions here, and then we can move to Saskatoon as well.
Please feel free. Anything having to do with psychology and the healthcare system, I'm glad to talk about. I want to go with wherever will be most useful to you. Yes?
Just curious if...
Hello, yes, thank you. Very good lecture. I was just curious if you know of any nation that has a model for psychological care that would be worth emulating, that provides essentially universal psychological care, like Canada is able to do roughly for physical care.
No, I don't. I think that part of the problem has to do with what professionals and what level of training are available, what's culturally appropriate for the particular country, and what the reimbursement schemes are. Just one example to take it to an extreme, when the tsunami hit South Asia a few years ago, there was a big move in American psychology and psychiatry. What can we do to go help? Well, it turns out that one of the most effective interventions was to train some of the village elders and the equivalent of being the village medicine man in things that would be stabilizing for people, because people weren't going to come in and talk about their issues in the same way, and they certainly weren't going to come in and talk to someone who was a Westerner who didn't speak and fit with the culture. But the idea is helping to show the ways that intervention works. My favorite example is if we only focused on helping people adhere to medical regimens, we would save millions of lives a year. And there's lots of reasons why people don't take medication as prescribed. One reason has nothing to do with mental health. That might be because they can't afford to buy it. Then there are the complexities of delivering the medication. If you're taking an HIV regimen that requires a cocktail of drugs that need to be taken in sequence, that can be complex. My favorite example of complexity, did you get the commercials in Canada of Sally Field telling you to take Boniva? Well, some people in the room might be taking Fosamax to help prevent osteoporosis, adenoid sodium. Take it once a week. Well, Sally Field's American TV star was pushing Boniva, which you only have to take once a month. And now there's a brand new medication called Reclast, which is taken as an infusion once a year. Well, duh. If you are such an idiot that you can't take the medication once a week, we're changing the medication to make it easier to help you adhere. So there's the complexity in the economics, but then there could be psychosocial reasons. And my favorite psychosocial example was that when I was 13, I had a plantar's wart on the bottom of my foot, and the dermatologist wanted me to come in the next week and have it cut off. And my Polish grandmother said, no, essentially, you should urinate on it for a week. So in order to be culturally appropriate, I let the dermatologist take it off, and I told my grandmother her advice worked. And so you get the cultural resistances, and then you can get psychological resistances. I'm not doing it because nobody's going to tell me what to do. I'm 15 and I'm fed up with this, or another example is my doctor doesn't like me. So whole social psychological literature was actually started by Irving Janis and Judy Rodin before she went on to become a college president on the adherent, what she called the reference power of the physician. Someone leaves your office, and this applies to us too. You're doing CBT, you're going to give someone homework. Will they follow your advice when they leave your office? If they think you care about them and are interested in them, they are more likely to follow your advice. But if you're a physician who's being told you have to see someone every 5 minutes, how are they going to establish that relationship with you? So I guess the bottom line is there's a ton of psychological variables where we could add value to reduce the morbidity of health and improve healthcare costs. And I'll just fast forward to one other thing, and I can give you the actual article if anyone's interested. I actually did a project in an HMO 10 years ago. We went into an HMO in central Massachusetts, and we intervened with people newly diagnosed with diabetes, people who had a first heart attack, or people who had a new cancer diagnosis. And we gave them up to 6 sessions of preventative intervention to help them cope. We called it medical crisis counseling. And then we followed up and looked at the economic cost offset. Now, we could only follow them for 6 to 8 months because we only had a 2-year project. We didn't do much economically to offset costs for heart disease and diabetes, but the cancer patients that we saw at a cost of about $300 were much less expensive than the cancer patients that got no intervention that ended up using $900 to $1,200 on average in mental health care. So afterwards, I was just so happy. I went to the HMO and said, so you're going to do this with all your patients now? They said, no. I said, why? I said, because of churning. People change insurance carriers every few years as rates change. So the people that you're intervening with may not be our customers in 5 or 6 years. So the long run isn't worth it for us. So if the insurer was made accountable, if they were going to get a bonus at the end of the year on some health quotient or satisfaction quotient of the population, it might force more of such services. More than you wanted to know.
Is there a question in Saskatoon?
No questions in Saskatoon.
And in the other location there?
Wait, someone's picking up a microphone. Someone picking up a microphone over there?
Question? None.
Is there somebody speaking? No, okay. Okay.
No question.
No question.
Hi, thank you for your talk. Do you know of any research looking at the difference in diagnostic rate and outcome between insurance-free providers and providers paid through insurance companies?
No, I don't, and you wouldn't be able to determine that because the insurance-free provider has no need or interest to track their outcomes unless it's the patients pay their bill, and they're not reporting to anyone. So, in essence, nobody knows except the provider and the client that someone's using their services.
And in your opinion, like based on your experience, would you think that the quality or the effectivity of the treatments are better with insurance-free providers or with the general?
Not necessarily. What happens is as you become more senior in the field and you stay around one territory or you publish or people get to know your name, they want you because you're the one to go to. Now, one example that Thomas gave me last night when we were sitting over dinner was he was told about a person in the community that might be suitable for some particular purpose, but was then told he's the only one in town that does it, but he's a jerk. Well, if you're unconscious and somebody's going to provide a procedure to you, let's say a neurosurgeon, I've always found them to be less interpersonally adept. But their clients are all unconscious or in a worse shape when they leave their care than they were at the beginning. So you don't have to worry about that. So when you build up a reputation, people want you. But now here's the really interesting part. In our field, we know that the knowledge of technique is not enough. You have to forge an alliance with the client. You have to get the client's adherence. I had a wonderful example last year. I still supervise trainees at the hospital, and I was supervising an intern who had a case of conversion disorder referred to her. And this was a kid who was seeing a neurologist, a pain specialist, an occupational therapist, and a physical therapist, and occasionally wearing a brace on her elbow and knee that had absolutely no medical purpose. And so we were working on, first of all, trying to get those other people to stop intervening, and second of all, to try to help this kid. And the intervention that this first-year psychology resident came up with, I never would have thought of. A young woman was sitting in the waiting room with her earphones plugged in, and she said, what are you listening to? And the youngster told her about the music and a particular song and the lyrics, which she knew, which had to do with abandonment and worrying about whether someone will ever love you, the typical angst of many of the stuff that's out there now. And it turns out that this was an adopted kid with a mother who was racially different, who had no contact with her birth parents, but knew one was in jail. And that familiarity with the music got the kid talking about stuff. And between September and May, she totally gave up the need for her braces and was walking and everything was fine. The conversion symptoms evaporated. But I never would have thought to ask that question. And if she mentioned the music to me, I probably wouldn't have known the song. So being able to connect with the client can be more important than your reputation or skill set. Probably the difference is if you're dealing with a surgeon because you want someone who does it all the time, does the same procedure repetitively. A few years ago, I needed to have a procedure, and because I was on the staff at the medical school, they said, well, do you want to go have this procedure done by the chief of service? I said, no, I know him. Aside from the fact he's a jerk. He's traveling all the time. I want someone who's going to be there when I wake up and who's actually going to do my surgery, not stand there while the residents do the surgery. So you make those choices. So some of those people who are able to have a private practice free of insurance may be wonderful, but there may be someone just as good for you who isn't in that venue. The challenge is to match up and finding them. And the real ethical thing to do, which is really hard to do, if you're in a system where there are options and choices, is if you have someone coming to see you for an initial appointment as a client and you're not the right person for them, telling them that I'm not the person you want and making a referral. Because you might see this, oh, another hour to fill my week, another procedure-rich way to increase my revenue stream.
Any other questions?
Jerry, you now know a little bit about the Canadian healthcare system and how psychologists are paid here, how services are paid. I guess at the most basic level, if this can be answered, is which system do you think is best from a client standpoint for getting the services, Canada or US? But at the deeper level, what are the advantages and disadvantages of each system?
I think in Canada, it would be easier to assure that everyone has some access to care. So if you have to wait, and if you have, maybe you won't get seen by a doctoral level provider, and maybe you won't get seen once a week or whatever you think, but you are more likely to get something. Being poor in America or being out of the mainstream in America makes it harder for you to get something, even though there are more mental health providers per capita. So I think that's a big difference. I think one of the things that really will be interesting is looking on the emphasis on quality. Very recently in medicine and in psychology, there's been a push for evidence-based practice and quality outcomes, and including, in pain research, for example, including quality of life measures as an outcome variable in studies. This stresses a lot of importance, and I think as systems get into that, it will be better for people. But right now, I'm not sure. I'm not sure where you would get the better service. I think it would be easier to find a psychological specialist in the States, obviously, especially in a metropolitan environment. But you'd be more assured that everyone could get services under the Canadian system.
I have another question.
I was just wondering, I'm obviously more familiar with the Canadian Psychological Ethics Code, but I know the American code shares a lot of things. And I just wonder how psychologists kind of justify in the U.S., like how services are provided to, let's say, the less fortunate or the ones that can't afford services. How does that play into the ethical code of psychologists? Yeah,
first thing I'd say is just for Thomas's information, the Canadian code is in the back of the book. It's in the appendix. You just didn't go that far. The APA code is split in two. Up front, we have the aspirational principles, and then they have the list of naughty things you can do and would get punished for it. The problem is, although we have things in the aspirational principles like every psychologist should provide some services free or at low cost, and that you really should be focused on human welfare, it doesn't radiate down to an individual responsibility. There's nothing in the enforceable part of the code that says if you don't deliver some free services, you're going to get your license pulled. I think that the profession in the United States that does the best at that is social work, because the National Association of Social Workers does have in their code, also in the back of the book, a big statement about human values and advocacy. Psychologists are a more diverse group politically than the social workers. And you're likely to see more psychologists arguing, well, wait a minute, advocacy for what? What you want to advocate for may not be what I want to advocate And so, the person who's doing very well in private practice has no interest in advocating for increased dollars to the community mental health center. I wish they would, but there's no interest. And you get to a wonderful point. What's the difference between the broader morality, which includes a focus on social welfare and caring about others and being my sister's keeper and stuff like that, as opposed to I'm going to follow the rules and stay within the lines for enlightened self-interest only. So I'm not going to break the law, but I'm not going to go out of my way to... And the best example you see of that in American politics now is Warren Buffett, who says, I am paying a lower tax rate than my secretary is, and that's wrong. And I'd like to see you raise taxes on people earning over $250,000 a year. Amusingly, I went to the Berkshire Hathaway stockholders meeting in Omaha this year, which is a very interesting cult event, and Warren Buffett and Charlie Munger, who are both in their 80s, sit there and answer questions. One of the questions one of the stockholders asked was, I'm a financial broker, and some of my folks don't want to invest in your stock anymore because you're letting your name be used on the Buffett rule to tax higher income people. And Buffett just says, well, when I started this company, I didn't give away my right to free speech, and I suppose they can invest somewhere else if they want. Next question. So here you have a person who's really advocating pro-socially for something, but not, you have other people that won't do that.
Time for one more question. Okay, Patrick.
I was just curious from your academic background, if there was any literature or much of a literature on the sort of the externalities of lack of coverage. Certainly, they'll look at the externalities of coverage, but by not insuring or not providing services, that has innumerable effects over many years and great cost economically and socially and individually.
The best example I can give you is again from my home state of Massachusetts. There was an article in the Boston Globe about a week ago on 5 hospitals that are losing money in Massachusetts. They lost money in the past year. And no surprise which hospitals they are. One was Boston City Hospital, which is the municipal hospital in the heart of the urban poor area with a very busy emergency room. Another one of the hospitals is Caritas Christi System, which was run by the Catholic Church. Interestingly, it's recently been bought by Steward Healthcare, which is owned by a venture capital firm. So we're all watching to see what they're going to do with the Catholic hospital system, which the church had to shed because it couldn't sustain the losses. But the hospitals that are losing money are the non-teaching hospitals that get lower rates of reimbursement, that don't have all this student labor of interns and residents being paid a relatively low rate to deliver services. They're serving the urban poor who might be uninsured or underinsured. Now, what the state of Massachusetts has done over the years is they will give some tax monies to offset care for the uninsured, which disproportionately go to these places that are losing money. How long that will be maintained and in what way gets to be an interesting issue. But that's the way that we've managed it in Massachusetts. There are other states that just don't bother, and the hospital has to close or the services don't get delivered. But it is really a very important issue. And again, the question is, philosophically, what is your government going to buy into doing? And the Canadian government years ago bought into the social contract obligation with its citizens around healthcare, and it may not be everything that you want it to be, but at least there's a floor. In the United States, our floor has a lot of loose boards and holes in it. And to his credit, President Obama is trying to fix that. At the other end, his Republican opponent, it was really interesting because there were a couple of pieces of the Affordable Health Care Act which everybody loves, like your kids who are unemployed and have graduated college can stay on their parents' health insurance till they're 26, and you can't be denied insurance if you have a pre-existing condition like diabetes or heart disease. So there are people saying, I don't like Obamacare, I don't like Obamacare. But wait, don't get rid of that part. Don't get rid of that part. There's a whole political movement in the States called the Teabaggers, referring to the Boston Tea Party and asserting your constitutional rights and freedom. And they say things like, I don't want you telling me that I have to buy insurance. I don't want you telling me that I have to do this or I have to do that. But you can't have an insurance system unless you have massive buy-in. Because the whole point of insurance is that the people who suffer the risks share that burden with the people who are protecting themselves against the risks.
And they also sometimes say, get your government hands off my Medicare.
Yes, they're exactly saying, get your dirty hands off. And one of the interesting challenges, and I'm sure this is true in Canada as well as the United States, in any society, you have a range of education and sophistication in the electorate. And you have some people who are going to seize on a soundbite. So what you have in the political campaigns is arguing for who can get the better soundbite. Because while there are people in this room who are well-educated and thoughtful and will parse all the arguments and try to pick the candidate who best aligns with their goals and values, there are other people whose vote counts just as much as yours who will make it because of some soundbite that they didn't think about twice, and which really isn't, keep your hands off my Medicare. So it is a dilemma when you go in to be a health policy expert, part of your job is not only to figure out what's the best policy for the greatest number of people, but also how do I sell this? One other little diatribe. When I was taking courses at the Kennedy School of Government, one of the courses that I took was in decision analysis, which is essentially a math course. You have to make a decision. They tell you all the factors that would influence your decision. And one of the midterm exam involved a city across the bay from a workplace. And the question was, we're running a ferry. Should we build a bridge or continue to run the ferry? And the math problem worked out that the bridge was more expensive initially, but cheaper in the long run. More people could use it, the maintenance was less than on the ferry, it was more reliable, and the math was just better. And I get the problem right, but when we're going over it in class, always being the provocateur, I raised my hand and said, what do you do if the mayor's brother-in-law owns the ferry franchise? And the person who was co-teaching the course said, that's politics, this is government. And his name was Michael Dukakis. And he was a very good policy wonk, but he did some really stupid things running for president that got him shot down. So the key is thinking about not only what is the right thing to do morally, and not only is how to make this manageable and work for people economically, but then how do you message it? How do you save it? How do you help them buy in?
On behalf of the Western Regional Training Center, I want to thank you so much for coming and speaking with us today. It was wonderful. Thank you.
It's been a pleasure talking to you, and I'm not going anywhere if people want to stay with us.
Yes, please do.